prolapses are uncommon, but as cataract surgeons we have to be in a position to deal with the emotional shock and the surgical challenge. Now in this case I've reduced the intraocular pressure as much as possible, and I'm now tile levering the prolapse back into the anterior chamber. It's quite pointless to try and push these things direct through the incision. Now I'm trying to proceed with the case, and I've inserted the handpiece, and the situation is simply going from bad to worse. The iris has become ensnared in the aspiration port of the phaco handpiece, and this operation is proving very difficult. So I replace the iris, and I'm presenting this case because at this point in time I'm wondering, what am I going to do now? Now it's a very good block and the patient is relaxed, so I'm closing the wound with a single suture of 10-0 nylon, and the operation is finished, but I'm starting a new one. I normally operate from the side, so I move around to the head to the 12 o'clock meridian. My staff are aware of this protocol and it's not too disruptive, and I begin a new operation. I'm refilling the anterior chamber with viscoelastic. I'm using a utility port from the previous procedure, and then with a 3.2mm diamond keratome I make my standard limbal incision. And then I proceed to my standard phaco, which is a divide and conquer using the slow motion technique of Robert Osher. Cortex removal is without difficulty. This is a foldable lens. I've put it in with forceps, and that's simply the placement of the trailing loop. I'm now separating ensuring separation of the iris from the initial wound with a flat spatula. The anterior chamber is being reconstituted with Myocol. As with all my cases, I sluice the anterior segment with betadine. This is the eye 10 days later with a vision of 20/20. I would value your comments.